Good morning, this is Erin with the Department of Medicaid. It is not quite 9:30 and we're still clearing the waiting room, so we'll give it just a few moments before we get started.
Sure thing. Oh my.
The doctor's office on the phone,
Okay.
not Mindy.
Okay.
It is now 9:30. Dr. Schuster, have you snuck in under a different name? Okay, I don't see her yet, so we'll give it just a moment longer. We're still clearing out the waiting room.
Meet Marquita for their session. They won't miss.
Good morning.
Good morning, Dr. Schuster.
Sorry to be a moment or two late. I don't know what happened to that last 5 minutes. How are we looking in terms of waiting room and quorum?
The
Erin?
waiting room, as soon as I clear it, it fills right back up. So we're working on clearing that out.
Okay,
And we have several members on that I've accounted for so far.
I'm hoping my microphone's not on.
yeah, we got a couple of notices of people that are not going to be able to attend today.
The waiting room is clear. I'll hand it over to you.
All right, thank you very much. And good morning, all. This is the first MAC, Medicaid Advisory Council meeting of 2025. Welcome to you. I'm Sheila Schuster, the chair. And Mackenzie, if you're ready, we'll turn it over to you for the roll call, please.
Yes, ma'am. Happy to do so. All right. Dr. Parton? Elizabeth Parton? Okay. Nina Eisner?
I'm here.
Susan Stewart?
I'm here.
Dr. Roberts? Heather Smith?
Bet that heart monitor's going berserk.
Dr. Bobrowski?
Here.
Dr. Compton?
Here.
Philip Travis? Dr. Gupta?
I'm here.
Philip
John
Travis is here as well.
Philip, got you. Thank you. John Dads? Dr. Hannah?
Here.
Barry Martin? Kent Gilbert?
I'm here.
Mackenzie Wallace? Here. Dr. Schuster?
Here. Mm-hmm.
Brian Proctor? Peggy Rourke? Eric Wright?
I'm here.
And Commissioner Lee.
And Commissioner Lee will not be here today. She's on vacation this week.
Yes, I'm
Lucky
filling in
her.
for Commissioner Lee.
Yes, welcome, Veronica.
Mhm.
Thank you.
Thank you.
Got it. Okay, so 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12.
Is that a quorum for us?
It is. I have 11 minus the commissioner, so we have a quorum.
Okay. And I know that Beth Parton is going to be joining us. She may just be running a few minutes late. We may have some others. I'd like to welcome Philip Travis as a new member of the MAC. He will be, he's replacing Dr. John Mueller and is representing the Kentucky Association of Healthcare Facilities. So welcome to you, Mr. Travis. The minutes were distributed, the court report of the meeting of November 21st. So I would entertain a motion for their approval from one of the voting members, please.
This
so
is
moved.
Nina Eisner. I'll make that motion.
This is
Okay.
Kent Gilbert. I'll second it.
Thank you very much. Any additions, corrections, omissions? If not, please signify your approval of the minutes by saying aye.
Aye.
Sir, okay, great, thank you. The old business item is the quick language access resources for providers. And I think that we had some good discussion about that at the last meeting. And I think that the commissioner was going to verify where we are with that. Veronica?
Oh, I apologize. I might have to phone a friend. Angie.
We will let you phone a friend.
Thank you. I was
I
not
think-
prepared for that one.
Yeah, I think that there was going to be a distribution to providers.
Mhm. Right. I knew we were
Dr.
working on the one pager.
Now.
Yes, and I will take responsibility for that. I've been working, this is Angie Parker with Medicaid.
I
I'm
am,
working with our internal communications person. We do have a one pager that has all the MCO information. So I will get that out to you all today or tomorrow.
wonderful.
Thank you.
We appreciate that. And I want to thank Dr. Gupta. Ashima has really pursued this. And I think the Consumer TAC has also done a lot of work on language access. So this is a great step forward. Thank you very much. And we will look forward to getting that.
Dr. Schuster, if I may, for
Yes.
just a moment to ask everyone who's not speaking, if they could please mute. There's a lot of feedback and small conversations. It's hard for the court reporter to capture everything when there's back noise. Thank you. Sorry about that. Tanner.
No problem. That's a good reminder, Erin. Thank you. And we also need the voting members of the MAC to keep their cameras on, right? Isn't that part of the open
During
meeting?
During voting.
Yeah, during voting. Okay. Excuse me. So we were looking forward to hearing from Commissioner Lee First about the survey results, the MAC changes and the creation of the BAC. And Veronica, I'll hand it over to you.
Thank you, Dr. Schuster. I do just want to provide a couple of updates before we dive into that, if that's okay, that the commissioner
Sure.
wanted us to convey. First of all, as you all know, there's been a change of administration at the federal level, and so we are closely monitoring that. There will be changes at Health and Human Services, the Department for Health and Human Services, as well as the Centers for Medicare and Medicaid Services. So we are, there have been some leaders nominated for those two agencies, but they have not been confirmed yet by the Senate. So there are acting representatives, including with the Centers for Medicaid and CHIP services, the Children's Health Insurance Services. The deputy director is stepping in, and we have a great working relationship with her. We did want to share that the current guidance from CMS is that you may have seen there were some executive orders that were issued on Inauguration Day to repeal some of the previous administration's executive orders. That makes no changes to our current program. If there is a change in what we're permitted to cover and what we are currently covering, that would have to occur either through a change in federal law, so a congressional action, or they would have to go through the administrative procedure process, which means posting in the Federal Register and repealing regulations that way. So just wanted to give everybody kind of a sense of calm in terms of what you may be hearing at the federal level. We are very closely monitoring it, both actions out of the White House and in Congress, and we'll keep you guys updated as you know, something that actually changes and requires us to do something. You know, we'll keep you guys posted on that. So just wanted to let you all be aware of that. I also wanted, oh, go ahead, Dr. Schuster.
I was just going to say, you know, we have a 1915I state plan amendment that has been at CMS for signature for a month or so. And we heard at the BH TAC yesterday that our Kentucky people are still working with the idea that it will be approved. But I assume that those things are still safely in limbo and not thrown out somehow.
That's correct. And we are seeing, you know, we are hearing from some of the staff that we work at CMS that we work with very closely, indicate, you know, there are some things they'll be able to move forward on, some things they're going to have to hold up. So they are communicating with us to let us know, you know, kind of what the current status is. So we're at least know that, you know, they're holding it. But we have not, for anything that's pending with CMS, which we've been maintaining a list to keep track of those things, any state plan amendments or other approvals that are necessary. You know, we've not been told that they've been denied. So they are just a little bit in limbo until, you know, they can take action.
Okay, thank you. That's reassuring.
Absolutely.
And good to be calm at a
Yes.
difficult time. So thank you for that.
We have to try.
Yeah, absolutely.
The other thing we wanted to mention, you've heard us speak to a replacement of our current MMIS, the Medicaid management system that processes claims and encounters. We were going to implement a new system called Medicaid Claims Administration and Financial Solution, MCAS, as we love our acronyms, and we constantly refer to it as MCAS. We wanted to let everyone know that we have stopped that implementation. We are going to maintain the current MMIS at this time, and we'll notify providers and members and other interested parties on when we plan to make a change other than maintaining the current MMIS. We were just having some problems with implementation and kept having to move the go live date, and have decided to not move forward with that new solution at this time. So We had talked a little bit about, impact to providers, and the changes that would come with that. So just as of right now, there are no changes. And then I know the commissioner likes to always give an update on Medicaid enrollment, and later on in the agenda, I can talk more about this, but we're hovering around 1,450,000 individuals. That's kind of the sweet spot right now for Medicaid enrollment. We're continuing to monitor that, but we have sort of flattened out as we've come out of unwinding. I'll give more information about that later on, as well as the Anthem transition. We'd like to provide an update on that, but I see it's on the agenda. So
Right.
if there aren't any other questions about those few topics, we will move in to the Medicaid Advisory Committee and Beneficiary Advisory Council, as we refer to as MAC and BAC. As you know, we did do a survey, and I'm happy to introduce Nicole Como. She is with Mercer, who is one of the consultants that's working with the department on all the federal final rule implementations, and in particular related to the MAC and BAC. And so Nicole has some information to share.
Thank you. I'm going to go ahead and pull up a slide deck for you all to refer to while I'm speaking, so you don't just have to hear me rattle away. It's great to be with you all this morning, and bear with me as I pull this up here. See if we can do this successfully without any issue. Here, you can probably see my full notes. I'm going to change into presentation mode here. Okay. Sorry, folks, give me one more moment. Okay.
There we go.
Thanks, guys, for the patience. All right. Let me switch this over one more thing here. Okay. All right. So hopefully y'all can see slides here. And again, I'm Nicole Como, and I'm a partner with Mercer. I'm very happy to be working with you all. I spent some time in a prior role and prior life in Kentucky at Connect. We have been working to conduct not only kind of a environmental scan of all Medicaid, MAC and BAC, and prior versions of MAC and BAC activity across the country, but also working with the department to put together the survey and some presentations with you all. I'm going to go ahead and advance slides here and talk to you all about how that was conducted and then the feedback that we saw. All right, so the webinars were held on Monday, December 16th and Wednesday, December 18th. from 1:30 to 3:30 Eastern, to provide background on the federal rules for the MAC and BAC requirements and to seek public input on the key decision points, both to ensure compliance with the federal regulations and ensure that we can enhance the process for external partner feedback, which really was outlined very clearly in the rule by the CMS partners. They want to ensure that states going forward really have robust voice from their membership. The Gov Delivery email distribution list, social media, and DMS website were used to inform the public about the webinars in early December. And the number of registrants was certainly far higher than we expected, but we were happy to see it. Ultimately, folks who were able to attend were smaller than those registered, but overall, we had about 350 participants in these webinars. For those of you that attended, we hope that, or watched the recordings, we hope that you'll agree that the topic of the MAC and BAC resulted in really thoughtful discussion with diverse voices. And individuals spoke during the facilitated discussion to provide comments through the Q&A function. The webinars included a QR code to the survey, and the QR code, survey link, and recordings were all posted on DMS's website shortly after the forum. Thanks, Veronica. I see a note in the chat that she's making folks aware of where those recordings are, should you still want to take a look. Okay, so let's look at some of the survey results. The survey questions focused on aspects of the current advisory structure in Kentucky, which is MAC and tax, as you all are well aware, and what aspects of that structure work well and what aspects of that structure might not work so well and have opportunity for improvement. We also wanted to know how MAC and BAC participants could be supported to maximize participation. We know folks have busy lives and lots going on. It's sometimes hard to make time to participate in these efforts. And so how we can best support that. The selection process for MAC and BAC members, any input on how that should happen, and other suggestions or comments related to the advisory groups in general. In addition to posting the survey link, the invitation was sent to 500,420 people, and it was posted on social media. We received about 668 submissions, and 502 of those submissions were really responsive to at least one of the survey questions, as to be expected, and often is the case when we have kind of engagements like this from Medicaid agencies. Some of the respondents provided comments relating to other matters in the program and or their individual circumstances or issues that they were hoping to have addressed by the department. So we excluded those obviously from the total count. You can see here some of the social media analytics and how many folks viewed those posts on Facebook. So some pretty significant interaction there as far as views. Interactions means folks who actually clicked on something and clicked through, and similar with the LinkedIn posts, about 269 and a 6% engagement rate. So when we dug into the survey results to see kind of who was actually responding, we used the self-reported affiliation to actually get a determination of who had responded to the survey. That said, there's some kind of nuance there that I'll share as we kind of walk through the slide a little bit. So the self-reported affiliation is presented here, but it might not be reflective of all forum attendees, given that many more folks participated in the forums than may have responded to the survey. And many submissions had multiple selections. So just to give you all a sense of what those numbers might actually mean. But despite that, based on the responses we received, we do feel as though feel very confident that those with lived Medicaid experience were actively participating in these forums. You can see there about 388 of the total affiliations selected were from folks who indicated that they had some sort of Medicaid lived experience. Right. So common themes. Given the time today, we're going to walk through things at a high level. Again, we're happy to answer questions and provide more information. But these slides will give a high-level summary of the key responses across decision points for the implementation of the MAC and BAC. And some of the themes are relevant to both MAC and BAC, and I'll try and call out which portions are for each as we go through, but a lot of the comments tended to be more general in their response to the questions, and so kind of associated with both MAC and BAC implementation. Again, I think it's important to remind folks that the agency will have discretion to make some decisions about this implementation, and then there are other places where federal partners were very prescriptive about how these two entities had to be established and how they needed to be operated. So as we go through, we're going to talk about external partner representation, the size of the MAC itself, publicly available information, virtual meetings, frequency of meetings, and open discussions was a few of kind of the very frequently commented on areas that we saw in the responses. Okay, so first, meeting frequency and format. Most respondents felt that the current every other month meeting cadence for the MAC was appropriate and should remain. However, this would require, and it's important to note, we thought for you all, would require under the federal rules that BAC members that sit on the MAC would have to meet basically every month or potentially twice within a month. This is because the federal rules require that the BAC must meet before the MAC meets going forward after this implementation this summer. Respondents also encouraged continued use of virtual meeting platforms and recommended meeting times outside of regular working hours. When it came to questions about the selection process, the federal rules require that the Medicaid commissioner select the MAC and BAC members. But if an application process is used for the BAC, respondents said that they would like it to be available in multiple formats and that individuals should have access to assistance to complete the application. Several respondents felt that the current nomination process by professional or advocacy groups worked very well and that the commissioner could then select from the nominations. A number of commenters also stated that they had interest serving on the MAC and BAC, so certainly we share that with the department as well. Once selected, we heard support for terms, the length of time that folks are allowed to serve on each of these committees. We heard support for terms for the MAC for 2 to 6 years. People shared that becoming knowledgeable about Medicaid can be time consuming. Certainly all of you are, I'm sure, well aware of that. And others said it was important that people have an opportunity to participate and that we have a broad range of folks able to participate, and so that shorter terms would obviously support that. Okay. Next, we wanted to talk about publicly available information. We received several comments from individuals that were unaware of the MACs and TACs, so generate some opportunity there for additional ways to make sure that information is being disseminated. Those that were familiar were generally very positive about the scope of publicly available information, but they also stated that watching 3-hour recordings could be difficult and that they would request more digestible information under the new structure. When we looked at the responses to representation for the MAC, we saw a lot of comments around expanded representation. Baby. Oh, sorry, is someone trying to ask a question?
No, I think it was inadvertent.
Okay, all right. I have my screen up, so I
Yeah.
can't see y'all, so I'll keep going. Thank you. Okay, so for the MAC in particular, there was requests for expanded representation for providers, including FQHC's federally qualified health centers and rural health clinics, as well as certified mental health clinics, chiropractors, dialysis providers, social workers. And there was also comments to make sure that providers that have the most engagement with Medicaid members were included. So kind of a nod to looking at utilization potentially across the Medicaid population and ensuring that those providers with the highest utilization and engagement with the population are clearly represented within the MAC. Very thoughtful comment, I think. There was also a desire to expand MAC to include representatives from legal aid agencies, and a number of notes about the importance of behavioral health representation from a number of the respondents. When it came to the back, there were suggestions kind of on both sides of the coin around Medicaid members and caregivers and how those numbers should be split and represented. I think the bottom line that came across in those comments were a desire to ensure representation kind of both, so that Medicaid members were certain to have a voice in addition to caregivers. There was also comments to ensure representation based on gender, age, geography, engagement with the behavioral health system, dual eligibles, and children with special healthcare needs. Okay. Sorry, I'm seeing comments. Oh no. Okay. When you got towards the end of the survey, there was a kind of an open-ended question for other suggestions and comments or questions on the development of new advisory groups. And so there were a number of comments there that we wanted to share here. I think that the most salient message was about member engagement, which was stated a little bit earlier, but there was a really strong desire for more opportunities for public engagement with the department. And there was also a desire for kind of two-way communication. So not just information being shared outwardly and posted publicly, there was a desire for additional surveys and online forums where members could communicate back to the department that was shared frequently in responses. Later in the survey, there were questions about what supports might be helpful, as noted earlier on, and there was a lot of feedback here from respondents. For BAC member supports, there were comments that the department should consider having dedicated staff to provide orientation, address public questions, etc. And current MAC members could also be considered mentors to both incoming MAC and BAC members. For BAC membership, there were requests for interpreters and stipends, meetings that were accessible in a number of formats, and also caregiver support. There were requests for transportation and childcare if meetings were in person. And a number of commenters wanted to ensure that individuals on HCBS waivers that may rely on caregiver and attendant support during those meetings were not having to use waiver services or hours for meeting participation. And I think that brings us to the end of the high-level overview. Again, we'll share this final version with the department, and it will be available to folks. And I think with that, Veronica, I'm going to pass it back to you. I would just really applaud the participation from folks who attended and the survey responses that we saw. It's really great to see folks engaged actively in how these new organizations will be formed.
Thank you, Nicole. We'll open it up for questions. If anybody has a question.
Yeah, I have a question. Nicole, can you put I'm sorry, I should have asked while your slides were still up. Could you?
Oh, that's okay.
Back up.
Yeah.
I'm trying to make sense of what slide goes with what you were saying, I guess. Go to, there was a listing kind of toward the end of, I think representation on the MAC. There were two columns back before that.
Yeah.
Back before that. Yeah, that one.
Mm-hmm.
So no.
Oh, go back this way.
Yeah, that one. because I note that behavioral health and mental health are highly represented. What's not clear to me is representation on what? Because I don't see that on the slide. Representation on the back or on the MAC? Is that what we're talking about here?
Yeah, the comments were pretty general. Folks didn't necessarily always indicate exactly where they wanted that representation. And we do know that, you know, there are behavioral health TAC currently in representation there, but it seemed like there was a desire for
But
more.
a representation on a TAC is not representation on a MAC.
True. It
Yeah.
seemed like there was a desire for representation on both, but there weren't specifics on exactly who they wanted represented.
So
Yeah,
this,
Dr. Schuster, so there was feedback to include somebody with a provider with behavioral health, or at least a member with behavioral health background on the MAC, and then to ensure that the BAC has representation as well from individuals, you know, with behavioral health or mental health diagnoses.
okay. I guess it would be helpful if you're not there to narrate this, Nicole. It's a little bit difficult from the slides sometimes to know what the responses are, to what
Yeah.
question are they applying, I guess.
That's fair feedback. We can adapt this to give some more clarity on what the questions were and how the answers broke down between MAC and BAC. We weren't sure how much time y'all would give us today, so
Yeah.
we'll update so that's more clear and before we send it back.
Yeah, and then I would appreciate that. And then go to the next slide because I'm trying to, I think the next one has a bunch of, so again, I don't know what this is responding to. Again,
Yeah, there were
both, and it may be both. But for instance, inclusion of social workers and case managers is a very specific thing. And were people responding to the MAC needing that or the BAC? Because you didn't have it listed in the list before. I'm just trying to wrap my head around what people
Yep.
were responding to.
Yeah, so we'll put some more clarity around those responses, Sheila. So the desire for social workers and case managers was for representation on the MAC.
Okay. So again, you see where I'm coming from. It's just because
Yeah.
we were looking at two different entities, although they are going to be intertwined. But any clarity that you could give around that, I think would make the results more useful to us.
So yep, we'll try and break up the representation and some of the other questions as well in a more simplified document.
So
Yeah,
are all of these groups, are they for the MAC on this
Because it's
particular
like-
slide?
No, and so just so that it's a little more clear for folks, there was a question at the end that was more open-ended and it asked for additional feedback that folks may have. And so we got a lot of responses kind of all lumped in different places. But variety of demographic representation we saw across both MAC and BAC. So for example, for the MAC, there was desire to ensure that there were federally qualified health centers and rural health centers participating from a provider perspective. On the BAC, again, wanted both Medicaid membership that were residing in rural and urban areas. So I think it went across both of the committees. So we can break this down and try and make it more clear about where folks wanted each of these kind of groups to be represented so that folks can see. I agree that the consolidated version for presentation makes it a little harder to understand who folks wanted to see where. So we'll put that together and get it over to y'all before the end of the week.
That would be great. Thank you. And Nina, you have your hand up.
I do. I'm just wondering about the recommendation that meetings be held outside of regular working hours. Was that for the BAC or the MAC? Or both?
So I believe both. There were comments around difficulty in getting provider engagement during working hours. Folks, busy providers bringing up their time to participate, and that would be challenging in some cases. And similarly for members, difficult for folks to take time away from work in some cases to participate.
I'm just not sure that's been a barrier for the MAC, but I could be wrong.
You know, another point to all this that I think we've described to you all previously as we look at the changes coming, forward, is that we're looking at other states. There are states that already have a BAC. And of course, I think every state has a MAC, but we're looking at best practices across the state and across the country, and to see, like if they hold evening meetings, how's that attendance, or what kind of supports are they providing to BAC members? How many resources does that state Medicaid agency need to provide that support? So we're trying to learn those lessons across the country to bring that, into Kentucky as we make these changes as well. So I wanted to note that because obviously we are, and this goes to the next item on the agenda. We are working on the draft legislation. And so the feedback absolutely is being incorporated, but also those best practices that we've seen across the country. We're also, trying to create something that we know has been successful in other places to bring that to Kentucky. So we do not have the legislation available yet to share. We're, quickly pulling it together. The General Assembly is set to come back on February 4th. And so we've got a short window that we've been working on it to try to get it in we think, a really great shape that's reflective of the feedback.
Nina, to your point, one thing for us to keep in mind is that, and I've forgotten the time frame, within the first 2 years of the creation of the BAC, 25% of the MAC membership will be made up of BAC members.
That's correct.
So it's going to really change the makeup and the flavor, certainly bring the voices of recipients and their families and their caregivers to the MAC in greater numbers than we've had. So, the timing, I agree with you that since we've gone virtual, now when we were meeting in Frankfurt, we often had quorum issues with the travel to Frankfurt and so forth. It's a lot easier for people to get on Zoom, so forth. So thank you for bringing that up. Do you have any other comment on that? No.
I have
a
Yeah,
question.
Ashima has a question.
Veronica, I had a question for you. Is there any particular state that seems to be a good role model for us right now?
Nicole, could you?
Sure.
assist with that?
Yeah, I'm happy to jump in. So there are a variety of states that we've looked at. And then just last week, CMS actually released a toolkit for states on how to come into compliance with these rules. And they highlighted a number of states that they worked with pretty extensively to get some best practices out of. I don't think there's probably one specific state that I would say is a best example for Kentucky, but there are a number of states with different pieces that I think based on the feedback that we're seeing and how you all have operated to date, that will, I think, be very good fits to share with you all for ways for you to think about how to move forward. So I would say there's probably about 4 states that have similar geography, similar type of Medicaid enrollees, similar size Medicaid population, and similar benefit structure that will help put together an appropriate set of states to look at. So that's also being compiled to be shared with you all in the very near future.
Thank you. I was just
Ashima,
curious.
I know I was on a national call about this, and they had Pennsylvania on. I think Pennsylvania is a state that has had a BAC for a long time, and it was very helpful to, to hear from them. I don't know geographically and in the kinds of ways that Nicole was talking about how similar. We don't typically direct our legislators to look at, we usually are looking at other states in the South. But anyway, Pennsylvania has had a BAC and provided support for them for a long, long time. So they've had that experience, certainly. I don't know how many states, Nicole, have tax like we do. I mean, not all states have tax or have the number of tax that we do. Is that right?
Yeah, you all are unique in that structure. I think many states in the work that we've done, and I didn't introduce myself fully, but I was the state Medicaid director for the state of New Mexico for 4 years. Many states have structures where they have subcommittees that are made up of a lot of the representation that you all have for your tax. And so that is something that we're going to share with you all as an opportunity as you look ahead. Pennsylvania is one of the states that was listed. And I think also North Carolina and Illinois have some good similarities to look at. I think also the number of tax that you have is unique. Folks seem to have smaller numbers of subcommittees that they use for representation. So that'll be something that I know y'all will be looking to evaluate as you move forward.
And I see that Veronica put the link to the CMS toolbox in the chat if anybody wants to look at that and follow up with it. Good question, Ashima. Beth, did you have a question?
I did. I can't figure out how to raise my hand.
Just wave at me.
Okay. So I guess this is to Veronica. Are we looking at keeping the tax?
I'll be honest, I'm not really able to talk about what the proposed legislation is. You know, there was feedback about how many tax we have. And I'm going to be candid and maybe go a little rogue in saying that we're concerned about maintaining the MAC, a new BAC, and then 18 tax that, you know, and especially if we're looking for representation on the MAC, and somebody who's also on a TAC, that goes both to provider and member. You know, we already have members that sit on several TACs. If we're trying to pull together a very robust BAC and make it meaningful and engaging, I think it really has to be a discussion about, can we maintain the current framework? We're going to be utilizing a lot of resources to support the federal requirements around the MAC and BAC already.
So when you're saying support the tax, you're talking about DMS staff wise or
I think it's a combination of DMS staff, but also, as I mentioned, I mean, if we're going to have representation on the MAC, on the BAC, and then also on the tax, I think we're just a little concerned about the you know, the pool of interested parties who want to be on the advisory committees. And you know, our focus, I think, should be on the MAC and the BAC and making sure that representation is robust and engaging, including, as Nicole mentioned, the subcommittees. So, you know, we're trying to figure out a way to make sure that we understand that providers like the tax and they feel like that's their seat at the table. That doesn't have to go away by moving towards a more robust MAC and a subcommittee structure.
Okay, I guess I would just like to say, based on my long experience being on the MAC, is that the input from the tax is valuable because we on the MAC don't know all of those things, all those intricacies that the tax bring to us. And so subcommittees that might be more generalized may not bring that same detail to the MAC. And so I guess logistically the DMS is going to have to look at that, of course, but from perspective of a MAC member, trying to make a good decision on advising DMS, the information that we receive from the tax is invaluable. So that's my input on that.
Yeah, I can't disagree with that, Dr. Parton. You know, I think the other thing to consider is that what we have seen, in addition to my previous comments, is that we see a lot of similarity in agenda items across TAC. So the department is coming and speaking to the exact same agenda item across multiple TACs. And so again, I think we're just looking at a way of what it, to your point, feasible, that maintains that interaction and ability for providers to engage. And you know, as Nicole mentioned, there's no other state that has the tax structure that we have. They have advisory groups, but they're generally on a subcommittee level.
Well, and to your point about the same issue being brought forward by multiple TACs, kind of is also informative, because it tells us that whatever that particular issue is affecting a broad range of groups.
You know, I think that the commissioner at a previous MAC meeting mentioned subcommittees, and, you know, I think, you know, one on quality, one on, you know, some of the audits and that kind of thing, having just survived a year of sometimes rancorous discussion at the BHTAC on audits. It's hard for me to imagine that being done in as meaningful a way, Veronica, if it's across all provider groups, because I think all provider groups see audits very differently and are probably treated very differently, which is not to say that the Medicaid rules about audits are not the same. But I think the impact that's going on right now in behavioral health is fairly unique. And I cannot imagine not having that forum for airing that, you know, and I may run that TAC very differently than some of the TACs, because we have probably 100 people on the TAC meetings every 2 months, because they are a source of good information and dialogue that would be lost, quite frankly, for both providers and advocates and consumers for that matter. So I guess I would have some problem with it, I think, and I understand where you're coming from. I'm also, and I have to say, disappointed that we're this close to the session going back in, and it's a short session, and there has been essentially no meaningful discussion with the MAC about this legislation. And it's, you know, I'm just going to be real honest and say it's very disappointing. We're supposed to be advisory to Medicaid, and it's real hard for us to act in an advisory capacity when we don't know what the discussions are behind the scenes. And, you know, when the commissioner gets back, I think I will take the opportunity to say, you know, at whatever point this legislation is going to get rolled out, I think we have to create an opportunity for MAC members at least to have some dialogue with the department about it. So
that's fair, Dr. Schuster, and you should know that we have indicated, you know, up the chain, leadership chain, that we feel like it's important for the MAC to see the legislation and to comment on it. So, you know, we've made that commitment to the extent that we have control over it.
right.
We've made that request.
I appreciate knowing that, because, you know, what I don't want to see happen, but it's going to happen if we don't, you know, work this out, is that a piece of legislation is going to get dropped, and all of the various groups, and it's everybody that deals with Medicaid, lots and lots of provider groups and lots of advocacy groups and lots of consumer groups are going to be upset with one or other piece of it, and they're going to talk to legislators about it, and it's going to be a mess over in the General Assembly in a very short time frame. So yeah, let's continue talking about how to make that happen. Thank you. Kent, you have your hand up.
I wanted to And very briefly, Dr. Schuster, I wanted to reiterate or underscore what you said. And I appreciate the complexity of this, but we have it was last year when we talked about legislation and ways that we could better communicate with the legislature. And there have been no responses from the department about that. We've had no interaction. As far as my knowledge, none of the MAC members have been invited to even speak with legislators, nor have we worked to get legislators. So now that there's legislation coming in, I think we know how this works. A lot of random things will be shoved into a basket is my fear. And not all of them are going to be helpful, nor will they help legislators know what's needed or us know how to best serve clients and providers. So I want to just add my me too to what you said.
Thank you, Ken. Anybody else on the MAC who wants to say anything at this point? All right. Yeah. Beth, yeah, okay.
Sorry. I want to echo what you've said as well, Sheila. I think that we need to be able to have input before the legislation is dropped rather than after.
Yeah.
I'll voice the same. Thank you.
Yeah, Kathy, thank you. So I think the message has been conveyed, and I'm sure that Veronica will take that up the chain. And I understand, Veronica, that DMS is not the final decision maker in this kind of process, that it's a top-down process, but I hope you will convey that you're going to have a mess over in the chambers. And I'm not threatening, I'm just saying people want to see this before it gets dropped.
Absolutely. Thank you.
Yeah, thank you.
Please.
All right, updates from the staff on Anthem leaving as a Medicaid MCO.
All right, that would be me. And I've got a presentation, very short. And if it's okay, Dr. Schuster, I'll take that item. And then the third item down was the renewals, but I've got them both in one presentation. So if it's okay with you, I'll.
Yeah, that's absolutely fine. Thank you.
Thank you. Okay. As you all should recall, we did announce that we were terminating Anthem as a Medicaid managed care organization effective January 1, 2025. They would no longer be an active MCO. And so we took the necessary steps in accordance with our contract with them as was a 60-day transition period. So we did start with a termination notice on November 1, 2024, and then we had various steps leading up to their very last day as an active MCO, which was December 31st, 2024. During that period of time, we transitioned approximately 170,000 Anthem members to other MCOs. Primarily, they were split between an automatic redistribution between Humana and United Healthcare. But members were always given the opportunity to change MCOs to whoever they wanted to, and that was honored during that period of time. So if a member was transitioned to and redistributed to an MCO, they could go in and update that, and that would be effective January 1, so that their choice was honored. So, we sent out notices to members and providers. And I'm happy to say that we saw a very, very smooth transition. We saw very little issue in that redistribution or changing of MCOs for those members. We saw actually little to no complaint of an actual access to services. And it, for all intents and purposes, went very smoothly, and we were very happy for that. That was a large number of individuals being transitioned. Just a reminder to folks that Anthem is required to maintain operations for various activities for run out, and that includes they still have to pay claims for any service through December 31st. So if you're a provider out there wondering about the payment of claims for those dates of service, you still can submit it the same way that you did previously. If you have, if they're denied, if a claim is denied and you want to appeal, they have to maintain all the appeals operations and activities all the way through it being completed. So if it goes to the external independent third-party review, or if it goes to administrative hearing, Anthem has to maintain those operations. So just know that those are still being done during the couple years that now follow their termination. We are maintaining the website. And so for those of you who want to learn a little more, we've got really robust frequently asked questions on that website. It's Kentucky Medicaid Anthem MCO transition, as you see there on the slide. We are also maintaining for at least 90 days the dedicated number for Anthem members. This is only for Anthem members. They can call that number and receive support for any questions they may have navigating that transition. So, you know, we certainly encourage Anthem members to reach out if they are having any trouble. But the call volume for that number has been extremely low, even prior to January 1. We were, you know, receiving only a couple of calls a day. And generally it was to request information about how to change their MCO. So they were fairly easy, not really about their access to care issues. So I'll take any questions on the Anthem transition from folks.
Yeah, I think there was a question in the chat, a follow-up from a provider who has accounts receivable. And if they're having trouble getting a response from Anthem, who would they contact at DMS?
Yeah, the regular MCO complaint process, and we can post that information in the chat.
Okay.
Veronica, I'm going to put that email address in the chat.
Thank you
This
so
is
much.
Chelsea.
Yeah, thank you very much. Nina, you have a question?
A comment. I was pleased that on our January 17th KHA DMS MCO call, Anthem did answer what I thought was an important question, and that is that if a patient is in an inpatient bed prior to January 1st, that Anthem will continue to cover the whole stay. I thought that was really valuable input.
Yeah, that's good to hear.
Yeah, thank you for mentioning that. They are required in accordance with our contract for any inpatient stay. It's until discharge. So even though they've been terminated, they are responsible for that.
Well, certainly that's the appropriate thing to do for the patient and not have any disruption and payment and concern and so forth. So thank you for sharing that, Nina.
The only caveat to that is if it's like a residential stay where it's a per diem, you know, that's handled a little differently. When the date of service crossed January 1, Anthem is responsible for payment of that per diem up until December 31st. And then starting January 1, the new MCO takes over. The new MCO is required to honor any prior authorizations. And again, we've not heard from providers having an issue with that transition for the per diem stays. And that by per diem, I mean, you know, they get paid a daily rate as opposed to on discharge as a typical inpatient hospital is.
That confuses me a little bit, Veronica. It's Nina,
Yeah.
because all of our hospital inpatient stays are per diem.
Okay, well, that's hospital, right? Mhm.
Okay.
Yeah.
Okay, got it.
Yeah, sorry.
Thank
It's
you.
residential, yeah.
Okay, thank you.
I have a question.
Yeah, Beth.
Why was the disbursement of the participants just to Humana and United instead of all of the MCOs?
So as part of our contract and our managed care model, we like to ensure a competitive component to the distribution of the enrollment. As you know, WellCare has the largest, Molina has second largest. And so when looking across and Aetna has Sky. So when looking across the MCOs and their enrollments. Humana and United were the lowest, and that was one of the factors in distributing between those two MCOs.
Okay, thank you.
But people could change after they were told who it was, so they could pick any of the MCOs to go to if they wanted to change. Yeah.
Yeah, we did see probably in the end between November 11th and the end of December, we saw probably about 5,000 transitions. And so we, in fact, members came in the week after they got their notice and made a change. You know, we did make sure that that was easy for them to do, that with no question, they were, you know, allowed to make that change.
Yeah. All right. Any other questions for Veronica? That's very helpful information to have, Veronica. Thank you.
You're welcome.
You want to go on to the unwindings and
Yeah.
flexibilities? This is your favorite thing to report on, I know. So we
Uh,
like to give you that opportunity.
Thank you so much. As you know, as I mentioned, we're kind of hovering around the 1.45 million individuals. We've seen that kind of leveling out from the beginning of the unwinding, and then that ended in April. You saw just a couple of, you know, we mentioned that beyond April, there were handfuls of redistributed members. We might have extended the members' renewal if they didn't respond as part of one of our flexibilities. So, but once we kind of got through that, and that was August was sort of the last month for any of the handful of renewals that were still tied to the public health emergency unwinding. We've now kind of landed in a little bit of a steady state. We do have our public health emergency flexibility still in place through June of 2025. As far as we know, that's going to stay the same. We'll let you know if that changes with the federal changes. But that includes the approval to automatically renew children. So when a child has a renewal right now, we automatically renew them and give them that 12 months continuous coverage. Starting with July renewals, we'll have to, we're required by CMS to actually perform a redetermination. So those renewals will be going out. We generally send it out about 60 days before. So in May, we will start sending redeterminations to cases with children for July. We are planning a lot of outreach and communication around that to make sure that everyone knows that that's happening. We're waiting a little bit longer before we do that as we get closer so that it's fresh in people's mind to do that. So you'll probably see a lot of social media and other campaigns around children having to go through a redetermination. There's been two additional federal rules that have happened. One is in November, CMS did release guidance on advising states on some of the flexibilities and how to make them permanent. They reviewed their federal laws and regulations to see, you know, within the discretion of CMS, what could we make permanent? So we've been reviewing those. There is interest, obviously. We care about our members and we want to try to keep people covered. So there's interest in trying to make some of those permanent, as well as the final rule that came out around eligibility and enrollment, and to make things easier on members. There's a lot of requirements around notice and just helping members navigate that renewal process. So that final rule was issued. Mercer and Health Tech is helping us with understanding those requirements. And so some of our flexibilities are actually captured in that as well, in terms of something we could do permanently, a change we can make permanently. So we're reviewing those as well, and we'll keep you all updated on what those permanent flexibilities we're going to be able to keep in place. A caveat that, this is a federal final rule, so not subject to just an executive order or the pause that you might have heard at the federal level, asking the agencies to pause any new regulations. So these are final. It would take additional action from either Congress or federal rulemaking, the administrative process through the Federal Register to make a change to that. So we'll keep you guys posted. And then we are continuing our reporting both monthly for the previous month's renewal, and then after 90 days, reporting any pending actions. So just to talk about that, just very quickly, I'm going to go through September as the last month that we did report our 90-day update. So on the left-hand side, you're seeing the number of individuals that were renewed. So 52,369 for September. The number of approvals, which was 45,833. The number of terminations was 1,234. And we had only one pending case. The pending case means we crossed over that end of the month and the member had responded. The state had not processed it yet. So we did process that one within that 90-day period. And as you can see over here, unfortunately, they've been bucketed under the termination. That's because we were able to determine that person ineligible. Moving to the past 3 months that we typically cover with you all, the last month being the December one. So just to walk through this slide, what you see is in December, we had 38,604 members who went through renewal. 3,235 were actually approved. 819 were disapproved. We have one that was pending as we crossed over on December 31st. And then the extended, I spoke about, is one of our flexibilities. So if somebody, for all individuals, if they do not return their renewal, we can extend them for 1 month automatically. And then for long-term care and 1915C waiver members, we can extend them up to 3 months for each month that they don't return that renewal. That gives us additional time for outreach and additional time for the member to return that information. So in December, when we crossed over December 31st, we had extended 4,549 individuals. And then we are also tracking this far right column here is our reinstatement. So currently under a flexibility, if a member comes in within 90 days following their termination, we are, and they're able to provide information and be determined eligible, we're able to automatically reinstate them back to their termination date within that 90-day period. So tracking reinstatements so far, we do see for December, we've already got 280 folks who have been able to be reinstated. And then, back to October, 848 have been reinstated. It's a great number to see. Obviously, especially out of the number that were terminated. These reports and a lot more information are available on the Unwinding website, so feel free to go out and check those out. It's medicaidunwinding.ky.gov. And we are maintaining a lot of all the information, in fact, including the flyers and informational bulletins about renewal and navigating renewals. These are helpful if providers, advocates, if anyone wants to pull them down and have them available in your offices to help somebody coming in that might be going through a renewal. We continue our request that, providers, when they're checking eligibility and they see on Kentucky Health Net that a member has an upcoming renewal, is mentioning that, making sure that they are aware and are responsive if they receive a renewal packet. And so that's what I have to share.
Great. And will you send that PowerPoint over to Erin to be put up on the website and distributed?
Yeah.
Thank you very much. Veronica, it's always good to get those. And I do feel like the Anthem transition has gone remarkably smoothly. We've not heard anything, at least I've not heard anything. So glad that that's going well as well. Let's go back to an item, and that is the possible restoration of prior authorization on behavioral health services.
Dr. Schuster, I'm sorry,
Yes.
there was a question in the chat about Veronica's presentation requesting if we know how many terminations were appealed and were reinstated. It said would like to see the stats on reasons for terminations, also the stats on appeals, how many people appeal because there is a lack of knowledge for beneficiaries. On this process, sorry, I had to scroll down, on this process, but it is intimidating to them, costly, etc. Did they have to go through the actual appeal process?
So Dr. Schuster, if it's okay, I'll respond.
Yeah, if you can respond quickly, otherwise I think, you know,
Yeah.
let's give that person, you know, somebody else to talk to, but go ahead.
So the numbers that I reported for reinstatement are not related to an appeal. Those are individuals who just through the normal process of discovering that they no longer have coverage, have or responded late, have sent in the information. So it's not related to appeal. I don't have actual appeal numbers available to me today. I'm happy to get those out to folks.
Yeah, I don't think we've talked much about appeals in your, you know, almost monthly presentations on these to the various TACs and so forth. If there's an easy way for you to include that when you said the PowerPoint, that would be great. Or as a follow-up to it.
Absolutely.
Yeah, thank you. Thank you, Erin. Now the question of prior authorization being possibly restored on behavioral health services.
So the department is currently in a process of obtaining feedback from various individuals, both from the managed care organizations and from providers. And then that just concluded that sort of that open call for information just concluded, and we're putting that information into a document so that it can be reviewed and then discussed. So there's been no additional decisions on restoring behavioral health, but certainly prior authorizations, but certainly, you know, we will have those conversations with providers prior to making any decisions.
I hope with providers and advocates.
Veronica, how was the request made for obtaining information or input from providers? I don't recall any.
So I was not directly involved in that process, but I think they tried to identify just various associations and representatives for associations, and then you know, provide sort of the largest behavioral health providers in the state to engage in that process.
Okay, I'll have to follow up with KHA. They should have been included, and I don't recall that. I could be wrong, though. Thank you.
Yep. And I can follow up with that, Nina.
Okay, thanks, Veronica.
Yeah, I think it came in an email from Commissioner Lee, Nina, and it was, I think, all the MCOs. And as Veronica said, some of the big providers. I was not included, which did not make me happy, since the BHTAC has talked about this more than any other group. And so I got a copy of the invitation and I inserted myself into the process and sent feedback based on the discussions at the BHTAC and some other information and so forth. But it was not I would not say it was a comprehensive list. Steve said the CMHCs or CARP received a letter. So it was big provider groups of behavioral health. I think there were a number of, I recognize some of the SUD providers, the larger SUD providers, but you know, my impression from the letter was that this was going to be an ongoing process. So, you know, I'm sure that they're looking at the input that they received. Excuse me. But I think that there will be further steps, and I think that KHA, you know, needs to be at that table, as do probably other provider and advocacy groups.
I've just received feedback from KHA, and the president did receive the email that y'all are talking about, and that's just been resent to me. So I'll follow up with that, Veronica. Thank you.
Oh, okay.
Mhm.
All right. So to be continued. We did get some, the BH TAC is obviously very involved in talking about this and so forth, and we will continue to be, so. The next thing is, update on waivers. Excuse me, my voice seems to be going. And I think Leslie said that she was not going to be able to be here, but Sherry Staley has that information for us.
Actually, Angela Sparrow's on and she's going to give the update.
Oh, all right. Well, we're glad for whoever is giving the update, but always glad to have Angela give us updates.
Good morning. Yes, happy to provide some updates on the 11:15 demonstrations. So again, do want to provide updates on the reentry. 11:15, as we know, again, there was lots of work that was occurring in 2024. So again, do want to report we were able to meet all of our deliverables that was due to CMS for the reentry project. By the end of the year. So again, although that we had received the approval of the demonstration, there were several deliverables that were still due. So we were able to submit those implementation plans, monitoring protocols, reinvestment plans that we've spoke to, evaluation designs. So all of those are with CMS for review. We've not received any feedback from those yet. So again, we continue to work with them, communicate with them on the reentry project as well as the other 11:15 projects. So we'll continue to move forward in 2025. We've kicked off again what the project plan looks like for 2025, still moving forward for a 10/1/2025 implementation date. So the first couple quarters of 2025, we'll continue to have and kick off some program design sessions, some, again, developing those IT requirements, working with our managed care partners. And again, we'll have some additional subgroups that are kicking off as well. And then we'll move through the spring and summer with readiness, testing, all of those activities that will occur prior to implementation. So good news there. In terms of the broader Team Kentucky 11:15, that includes again the SMI SUD 11:15. So we did receive approval and extension in December, mid-December from CMS on those other components that had been pending. So we do have approval again for the SUD SUD substance use disorder extension, another 5-year extension, and then the approval of the SMI 11:15. So very similar to the reentry project that we've spoken to, there are still additional deliverables that are due to CMS. So we're working again, taking a look at those and building out the timeline for the broader Team Kentucky extension and implementation and what that looks like through 2025.
And Angela, excuse me, those are the pieces for SMI and SUD would include more days in the hospital and medical respite, or I forgot you call it something besides medical respite, but, right?
Yes.
Those are in the 11:15.
It is, yes, Dr. Suster. So medical respite recuperative care is included in the broad Team Kentucky. So it's actually outside of SMI. It is after discussions and negotiations with CMS, it's considered what they call a health-related social needs. So those health-related social needs demonstration opportunities. So it is under a health-related social needs 11:15 opportunity. So again, it will have its own implementation plan in components very similar to the others. But all components, again, were approved through December 31st of 2029.
Okay. Nina, you had your hand up.
I do. I have a question for Angela and then back to another question for Veronica. Angela, if you could clarify for me, please, which provider groups are being involved in the reentry 1115 waiver conversations? Incarceration is a really big issue with hospitals, particularly with local jails.
Yeah, unfortunately, local jails are not part of the reentry waiver yet. It's prisons and juvenile detention.
Ah,
Yeah,
okay.
I understand, and maybe Angela could speak to this, that they are beginning some outreach to local jails, but that's not part of what's currently going to be implemented in October, Nina.
Okay, well, that's good to know.
Is that right, Angela?
That's correct. Yes.
Yeah.
And then a question back to Veronica on prior auth. I'm sorry, I'm a step behind. If prior auth is restored, will DMS give direction to the MCOs as to how much notice providers have to get before that PA is turned back on? Or will that be up to the MCO's discretion?
No, they will have to give a minimum of 30 days, but we've been trying when there are changes to give, 60, even up to 90 days if possible. So there'd be at least a minimum of a 30-day notice.
Thank you.
Sorry, Angela, we've interrupted your train of thought here in presentation, but so you were telling us about the 1115 SMI SUD waiver.
Correct. Yes. So again, we received those approvals. The substance use disorder demonstration, again, that does not require any additional implementation plans. We can continue forward. So again, the SMI 1115, we will need to still submit monitoring protocols, implementation plans to CMS in those deliverable dates. So we'll begin to continue working forward on those. And then again, I think we can provide in the next an update in what that implementation timeline looks like.
And then what about the timeline for the SMI 1915 iSpa?
Holland might be on to provide an update on the.
I'm here. Sorry, it's hard to find the audio button to unmute yourself. As you heard yesterday, Dr. Schuster, DMS officially submitted the 1915 I state plan application back to CMS on Friday, January 17th. And as of today, we do not have approval, and our timeline is really contingent upon that approval. We are still looking towards a 7/1/25 implementation date. Our goal is to begin training and onboarding providers 2 to 3 months in advance of the go live of RISE. System changes, of course, for provider enrollment, billing, and integration of the functional assessment tool are all key factors associated with implementation. I will say that the regulations for RISE initiative have been drafted and are under internal review, and that DMS does anticipate filing those with LRC in February.
Yeah, there was a question in the chat from a provider about when would providers be trained. So if we're go on July 1st, then 2 or 3 months before that would be
Yes.
training. Is that right?
I mean, 2 to 3 months live, I think, before we implement, where we're going to start taking on, assessing individuals for services. So, yeah, I don't want to say it would be April. I don't know. It may be April. It may be we start July. I don't know yet that exact date, but we plan to have the providers onboarded. That's definitely first.
Okay.
Which is a certification process through the Department for Behavioral Health, Developmental, and Intellectual Disabilities.
Right.
Similar to waivers, but there are certain things, right, that are similar to our waiver, but this is a state plan,
Yeah.
home community-based services.
And I think that there was some discussion at the BH TAC meeting yesterday that somebody would reach out to CMS and make sure it's still sitting over there.
I do believe Deputy Commissioner Hoffman stated that she would have Jody. Jody, if you're on here, I'm sorry, I'm kind of putting you. Maybe tomorrow, if we haven't heard, that she would reach out to CMS on Friday, is what she reported.
Yes, hi everyone. Yeah, this is Jody Allen, behavioral health specialist with Medicaid, and I'm working alongside Ann on this project for the 1959 SPA. And yes, our plan is to reach back out on Friday. There's been obviously a national administration change, so we know that the timing of this is kind of tricky. And so we plan to reach back out on Friday to see if we can get some additional information.
Great. Because there's a lot of anxiety, and the absence of information is bad for anxiety. So
trust me, Dr.
Well, no, yes,
we are definitely in that boat.
Yeah, you're living with it too. You don't have any more information.
Yes,
We're doing a lot of deep belly breathing.
yes,
to remain
yes.
calm. Yeah,
and we're continuing to work on everything as if we are moving forward.
Right.
So we are not losing momentum at all. Just need that official word. Yeah.
Yeah.
we meet quite a bit, so at least weekly, but communication all week long. So
Yes.
we're not waiting on anything. We're moving. We're
moving forward. Yes.
Yeah.
Moving on. Okay, that's what I wanted to hear. Thank you very much.
Thank you.
And then Angela, are you doing the current HCBS waiting list numbers?
I'm going to actually pass that over to Sherry. I think she has.
Oh, okay. Great. Thank you.
It's a round robin here today. Yes, I have those numbers, and they went ahead and re-pulled them yesterday. So these will be updated just a little from the behavioral health TAC. So as of 1/22, 3 waivers have current waiting list. The HCBS is 2,823. The Michelle P. waiver is 9,434. And the SCL waiver is 3,531. And the total unduplicated waitlist members is 13,992.
Ooh. Thank you, Sherry. Have all the people that were funded in this last budget session, I'm sure not all of them have come off the waiting list and been enrolled, but do you know where we are with that process? And if you don't have that right now, but I we got a lot of funding to put a lot of people into waivers.
Dr. Schuster, this is
Yeah.
Alicia Clark. So all of the funding from the legislator in the budget for those slots, they all have been released. That finished up the end of October. Now, obviously, everybody is in different phases, right? In getting services, applying for eligibility, all of that. So spots aren't really, I'm going to say, earmarked, saying this is this budget year, that kind of thing, because we are constantly reconciling, all the time, because people unfortunately might be deceased. We can open those slots back up. Individuals are not interested in waiver anymore, so those slots can be opened back up. So we're constantly reconciling. But as far as all of the slots, we had a plan that started in August and that ran through the end of October for our Michelle P. waiver and our HCB waiver. And all of those slots were released to individuals on the waiting list.
So I guess my question, that's really helpful information, Alicia. So my question is, are those numbers, have they been subtracted from the waiting list numbers? So they're not being listed still as being on the waiting list?
That's correct. So once they
Sherry
get
gave us.
capacity, they do, they're like in a different bucket, right? So we do have people coming on daily. That's why you could pull our waiting list numbers today. They're going to be slightly different than they were yesterday.
Yeah.
It's really a fluid in that. So, but yes, those people that were on the waiting list that received slots would not be on the waiting list anymore.
Okay. So while we were celebrating funding from the General Assembly for many, many more waiver recipients to get services, it's not really made a dent in our waiting list when I look at these numbers. I mean, unduplicated numbers are almost 14,000 people.
Yeah, I do hear what you're saying.
Do
Yeah,
you see
I
what
do
I'm
hear what
saying?
you're
I was actually hoping that maybe they hadn't been subtracted out yet.
No,
But,
no,
no. So we've got 14,000 people again waiting for waiver service.
yes,
All
that is correct. And there are additional slots, and I apologize. I don't have those numbers right in front of me. I want to say, and again, don't quote me on this because I'm not 100% sure, but I believe for HCB and Michelle P. Waiver, there are 500 additional slots that will be available for fiscal year 26. And we are coming up with a plan to start releasing those in July when they're available within the budget. And, you know, again, and we come up with this plan, we don't want to release all 500 at once, right? Because then you create a bottleneck.
Right.
Which we definitely don't want to do. We understand our providers have to have the individuals, the staff to be able to take care. So we will come up with a similar plan like we previously completed this past year to address those new slots starting in July.
Yeah, thank you.
You're welcome.
Kent, you had your question up.
Yes, thank you. And
I'm sorry you had your hand up.
yeah, thank you. And several of them are in the chat as well. I have a lot of questions about the data that I think is not clear to me, and that may just be my lack of understanding, but this seems substantially higher number of waitlisted folks. So I guess I have the question of how are we, what is our plan here? Because the numbers going up is not part of the hope, I know, of the department and certainly not of us. We've increased funding and yet the numbers have tripled or not tripled, but have gone up. Is that because we have more applications? Are we having are there more folks applying?
We do have folks every day that are applying. We are currently in one of our, I want to say, reports that were due to the legislators. That is one thing that we are currently working on is how we can better manage our wait list. And so we are working through that. That, of course, is going to take time, right? Possible regulation changes and all that. But we are doing the research right now to see what we can do to assist. And I know, obviously, I think, and I'm sorry, I can't remember if it was Sherry or Angela or who spoke on this, but, you know, we do have the possibility of maybe a children's, and I'm going to call it a waiver. It's not a 1915C waiver. It'd be like maybe a 1915I or 1115. But, you know, we're looking at something that would be driven toward kids and just overall what can we do as a state to get services that are necessary for our individuals. And I don't have the latest numbers right in front of me. I believe they were at the beginning of this month, but it runs about 80% of the people on waiting list do have current Medicaid eligibility. So they can get services through, you know, all of these state plan services. Those are available.
Are we doing any kind of triage? I mean, in other words, clearly everyone is in a different kind of setting, and pediatric patients in particular. I think Ms. Browning's comments are apropos that, you know, we're ending up causing, by delays, we're causing expenses to be shifted down the road. I mean, do we have any system by which we, like, certain cases are prioritized?
So that is one of the things that we're looking at with the waiver waitlist management work group, because currently the way the regulations are written, except again, every regulation is different, right, for every waiver.
Yeah.
But with SCL, there is more of like a prioritization with they have future, emergent, and urgent categories. Whereas, for instance, Michelle P. Waiver and our home and community-based waiver do not have that information within the regulation. But that is something that we are taking a look at on if we need to establish categories and what that looks like. So again, that's all in the works very early on, but we are working on that.
Yeah, I appreciate the complexity, but I also want to communicate strongly the urgency of this. This is, that this is families' lives, and certainly the folks that I know who depend on the kind of support that can only come with a waiver. Being on Medicaid is not a substitute. There are supports that can only come. So anything that we can do as a MAC on tax, in whatever ways we need to, find better ways to either fund or process these. I feel like that's got to become a priority that's higher up on the list than apparently we've been able to achieve.
And and I apologize if I missed this, but were you speaking to pediatric patients?
No, I mean them all.
Okay. Okay. I thought you had said something, and again, early intervention definitely is key. I wholeheartedly agree with that. And a lot of the medically, necessary services, those are available in state plan, our therapies, all of that. So just wanting to make sure that, that people are getting the services that they need. And I apologize. I think Deputy Commissioner Veronica Judy Cecil had maybe come off mute. I think she went back on mute, but if she had something to say, I will definitely let her speak out, take over.
Thanks, Alicia. You mentioned the wait list report that we submitted to LRC, that Legislative Research Commission, that included some recommendations, and we are reviewing that right now on how can we improve management of the wait list. I think ultimately the only thing that's going to solve this problem is more money.
Yeah,
we need more money.
Absolutely.
It will not be solved with a wait list management. The children's waiver, we hope might help with some of it, and we do have some funding for that. But ultimately, people are going to continue to be put on the wait list, which I just would like to clarify. Being on the wait list does not mean you're actually eligible. The eligibility is not determined until a slot is available and the person is then goes through an assessment to determine eligibility. And that's been part of the problem too, and we understand that's hard to understand, is that, people can just put themselves on the wait list. There's no assessment to determine that you're actually eligible for that waiver until that slot's available. So, that's part of our, what can we do with the wait list management too, to make sure those on a wait list are truly eligible to benefit from that waiver.
I just want to reiterate, thank you, Veronica, that this is what we're seeing, Kent, is a combination of things, but the major factor here is the lack of funding from the legislature over many years, where they have dribbled and drabbled out, maybe 150 new slots in each of the waivers each year of the biennium, or at the most, we thought it was wonderful if we got 250 slots, and so forth. And it was huge this last go around when we got funding for 1,950 slots in the combined waivers. I mean, we were celebrating because we've never gotten that much money. And that's why I was so disappointed when I asked Sherry, or Alicia, are those numbers still reflected hopefully in this 14,000, and they're not. So part of it is that I think the waivers have not, they are increasingly being known by people. The network of parents of young children who are born with significant disabilities is growing, and people are just learning about waivers that they were never told about when the child was first diagnosed, which is, a problem in the system. We've talked here at the MAC about how to make Medicaid and Medicaid waiver services more available. And one of the things the commissioner has said is, there's a downside to that. So we get more people who put themselves on the waiting list because they know they need those services, and they find out that their child can be available for those services, even though their family income, would not make them eligible for Medicaid and all of those kinds of things. So I think that's the increase in numbers. And it's, you know, the need is there. The need has always been there. Anyway, there are lots of pieces of this. And I do think that it has to be an ongoing, and I would hope, in fact, there's a lot of interest in serving on the back from some of these parents and some of these caregivers, some of them with children who are now in their adolescence or early adulthood, who have struggled with this system over many, many years and really want to have a voice on the back and eventually on the MAC. So I appreciate your bringing up those issues, Kent, because it certainly, and we probably have spent more time since I've chaired the MAC talking about waivers, because that's the world that I've lived in with children. And, you know, it's a critically important part of Medicaid. And I think a lot of the provider groups that are on here really have not had a lot of knowledge of or been very concerned about, because that's not who they're serving. But it's, you know, it is a critically important part of Medicaid, and we really need to pay attention to it. So appreciate this discussion. Anybody else have anything? Let's go on then to the TAC reports. I think that's next on the agenda. And I apologize that I don't have a written report. We just met yesterday afternoon, so it was a little hard to do that, but we did meet yesterday. We had a quorum. We had a presentation from Medicaid on their statewide behavioral health needs assessment, and some excellent dialogue around that with some, we're going to get an updated version of that with more information. We did receive updates on the waivers, and we were disappointed that the 1915I SPA, which is the one that would give supported residential services to people with severe mental illness, did not get across the finish line with the CMS approval before the change in administration. So we very much appreciate that DMS is continuing to work on it and still holding to hopefully a July 1 go live date, but the future is unclear. We were also pleased to hear that the folks working on the reentry waiver have begun to do some outreach to local jails. Many of us, when that waiver was first submitted, you know, were very strong on the fact that the local jails needed to be included in that. We continue to discuss pre and post payment audits by the MCOs and the possibility of prior authorization being reinstituted for at least some behavioral health services. It has certainly been the impression, the strong impression by the members of the behavioral health TAC and those in attendance, that as prior authorization has been suspended, the number and scope and extent of these audits has skyrocketed. I mean, it's clearly a punishment in a sense. It's the MCO's way of saying, okay, you're not going to let us do prior auth, so we're going to just audit the heck out of you after the fact. Anyway, there was a lot of tension about that. We do not have any recommendations, and we will meet again on March 13th. Thank you. And how about the Children's Health TAC? Is there anybody here?
I do not see anyone on. They met January 8th.
Okay. I am concerned that I don't think have had a report from the Children's Health TAC. Maybe since I've been chairing the MAC.
They only had 2 members present last meeting.
Yeah, well, you know, thank you. Consumer rights and client needs. I know.
Yes, I'm
There's
standing.
Miranda. Great. Yeah, good.
Hi. So yes, I serve on the consumer TAC, and we met remotely on December 17th. We did have a quorum. We discussed language access and really appreciated today hearing an update on that. We also discussed the access to services and care and the complaint form and linking to the network adequacy one-pager. And then we discussed how all surveys, public forums or meetings, and public comments periods, and really that they should be shared with all Medicaid stakeholder email distribution lists and on social media channels. But our specific December recommendations that we agreed to put forward were regarding the BAC and MAC, or really the BAC. So the first one was that current consumer rights client needs TAC organization membership be included as part of the BAC in addition to other seats that are included through the public nomination process. And the second recommendation in December was that in planning for full diversity of Medicaid members on the BAC, that DMS consider literacy in any materials. And then we met again in January, specifically to spend more time discussing the BAC. We were short on a quorum, but would still like to share the recommendations that we discussed. And so in January, that was one, that the BAC should conduct meetings that are open to the public at least 4 times a year, but not be required to follow public meeting laws to allow flexibility for planning meetings and technical assistance. 2, that the BAC and MAC should adopt a formal policy on accessibility and accommodations to support meaningful participation. These accommodations should include, but not be limited to, language services, personal assistance, communication supports, and other supports and resources as needed. Excuse me. 3, that DMS should work with the consumer TAC to create a BAC nomination and application form and process for selecting BAC members. 4, that DMS should provide dedicated staff support with 1 or more DMS policy staff assigned to support BAC members with individual technical assistance between meetings. 5, the BAC should have staggered terms of a minimum of 3 years and a maximum of 6 years to allow members to develop and share expertise. For BAC members selected to serve on the MAC, their term should be extended. 6, that DMS should consider the BAC members are offered reimbursement for expenses and compensation / stipends for their time, modeled after standard boards and commissions. 7, the BAC should include a minimum of 25 members, with 7 of those members nominated by the existing organizations that make up the consumer TAC, being the National Association of Social Workers, Kentucky, the Kentucky Legal Services Corporation, Office of Kentucky Legal Services Programs, the ARC of Kentucky, Department of Public Advocacy, American Association of Retired Persons, AARP, Family Resource Youth Services Coalition of Kentucky, FRISKY, Kentucky Association of Community Health Workers, KYACHW. And finally, the additional 18 members of the BAC should include a diverse range of representatives based on geography, age, race and ethnicity, sex and gender, LGBTQ+, disability, language, and physical, behavioral, or oral health needs. And that is my report. Thank you.
Wonderful. I love those recommendations, Miranda. Thank you. And thanks to the consumer TAC for their input. They're in the ideal place, excuse me, to be making those recommendations. So I appreciate that very much. Thank you. I think the dental TAC did not have a meeting. Disparity and equity TAC.
I've got just a little report though.
Oh, okay. I'm sorry, Garth.
I'm sorry. We did not meet since the last TAC meeting, but we do have a meeting scheduled in 2 weeks. But we do have some new members that are coming on the TAC for now. And thank you, Aaron, for sending out those orientation packets. But we don't have any official report today. Thank you.
All right. Thank you. Thank you very much, Garth. The disparity and equity TAC.
They have not met. They're working on having their members reappointed, and a couple have applications pending. So they're working on rebuilding their membership currently and are scheduled to meet in April.
Okay, thank you. Let's see, EMS, I think Keith got back to us and said that he couldn't be here today, and I've forgotten, Aaron, did he say that they had not met?
They meet next week, and
Okay.
their goal is to discuss the legislation that
Right.
impacts ambulances.
Okay, thank you. Home health.
Thanks, Dr. Schuster. Evan Reinhardt with the Kentucky Home Care Association. So the Home Health TAC met on December 10th and discussed an update on electronic visit verification, as well as the supply fee schedule from the MCOs and supplies limits, which continues to be an issue for us, and asked for an update on our home health reimbursement rate recommendation from a ways back. And then on the new business side of things, discuss credentialing issues that providers are having their numbers expire prior to being revalidated. And finally, one area of concern for us is home health aid utilization and how that's been decreased and seems, to be somewhat associated with the launch of managed care in our space. So we're keeping a close eye on that and asking for some data there. And we did not have any recommendations from the December meeting.
All right, thank you very much, Evan. That's a good report. So are aids not being approved by the MCOs? Is that what you're seeing?
That's correct. So aid services are typically not authorized in the way that they had been historically. So that's obviously led to a decrease in hiring of home health aides on our side, just from a workforce perspective. So, and then likewise, workforce issues, those individuals are, an important part of our industry. So we're just keeping a close eye on that.
Yeah, certainly the workforce issues continue to affect all of us, I think, but that's an important part. Thank you for sharing that. I know you will keep an eye on that. Would be interested in hearing that.
Absolutely. We hope to have an update next meeting. So we'll share that when we get it.
Yeah, thank you very much. Hospital care.
Russ was on. He may have had to drop. I believe their last meeting was in December, and they're scheduled to meet in February.
And I assume they didn't have any recommendations, Aaron?
No, ma'am.
Okay. All right, thank you. Intellectual and developmental disabilities.
Morning, Dr. Schuler. I'm Wayne Harvey. I'm the new chair of the IDD TAC. We don't have any formal recommendations to bring forward to the MAC, but we do have two particular items that have kind of dominated discussion over the last couple of meetings. One being involuntary terminations. This has been a longstanding issue for the IDD TAC, and we're in the process of continuing to gather information and bring forward a formal recommendation to the MAC. The biggest thing that is of concern to us is the number of people that have been terminated that still haven't found another provider, and the number is 12 for over a year. Just to give you some background on this, back when SCL transitioned into the SCL2 waiver, they changed the involuntary requirements around termination, and they made it where providers had to continuously serve someone, even though they're indicating that they can't meet their needs. They can't, in some cases, can't safely meet their needs. They have to continue to serve them until another provider is secured. So that continues to be a huge concern, not just to providers, but to the to the participants themselves, family members, guardians, advocates. And that's certainly something that we'll be bringing a recommendation forward on soon. The other issue that continues to concern the IDD TAC is the implementation of the rate study itself that Medicaid required providers to participate in and complete. We completed the rate study. It's almost 2.5 years ago now. And they implemented 70% of the rate study itself on January the 1st of this year. The issue with that providers have and people on the committee that's concerned about this is that by the time we get to 100% implementation of this, the numbers are going to be 4 or 5 years old. Obviously, and there were things that were contained in this rate study that, you know, pertain to inflation and things of that nature that was built into this. So those are the two primary things that are really on the radar of the IDD TAC and really causing us a lot of concerns.
All right, thank you for sharing that, Wayne. I'm glad to have you join us in both of those. You know, I hear about involuntary terminations and you know, I know that that's a big issue, and obviously all of us are concerned about rates, but when you make a recommendation 2 or 3 years ago and then it takes that long for it to get implemented, you're right. You know, the rates are already too low or outdated or, you know, whatever before the ink is dry. So keep us posted on that, and we'll look for your report in another 2 months, because you will have met, and maybe we'll come back with some formal recommendations.
Yeah, we met in December, and we've got a meeting coming on February the 4th. So
okay,
we've got one that's very soon.
Yeah, great. Thank you so much. Glad
Thank
to
you.
that you've put those on the radar for us. Nursing home care, please.
They have not met. They're scheduled to meet in March.
Okay. Thank you, Erin. Nursing services.
I believe, sorry, excuse me, I choked on my beverage. I believe they're scheduled to meet next month. They met in, I believe, October last.
Okay, thank you. Optometric.
Yes, Steve Compton from the Optometric TAC. We have not met since the last MAC meeting. We do have a meeting scheduled for February the 6th.
Thank you, Steve. We'll hear from you then when we meet in March.
Yes, ma'am.
Thanks. Steve Shannon, persons returning to society from incarceration, the longest named TAC.
Correct. And perhaps the most important TAC. I'm not sure.
I'm sure.
Just kidding. We met in January, and it was really nice because Angela Sparrow kind of gave my report for me. Obviously, we paid a lot of attention to that reentry waiver and the progress being made. I want to commend Medicaid for hitting all the timeframes they had to with their implementation plan, their monitoring protocol, and their evaluation plan. And again, we are all looking forward to July 1. We're also pleased with the CAA. That's serving youth in jails, 18 to 26, or youth development centers. I think that creates a vehicle to develop relationship with local jails, because obviously the waiver is just for Department of Corrections facilities. There's a lot of local jails and there's state inmates there. So I think we're pleased to hear that report as well and looking forward to it. We always get updates from our 5 MCO partners, and they really started doing a lot of in-reach, working on that reentry piece, even though it's not a waiver, making those connections as soon as they can, partnering with local groups on councils to facilitate that process of transitioning back to society. Obviously, that's a big challenge, and a lot of questions, a lot of needs are at that point. So we appreciate that work. We have no recommendations. We anticipate once we see the waiver and start implementing it, we'll probably have more ideas of what we're going to move forward. But right now we have no recommendations, and we're scheduled to meet again in March. So thank you.
Thank you, Steve. I think we're all excited that waiver is going to move forward, because the numbers of Kentuckians that would be served are pretty astronomical, and particularly if we get the jails involved. So thank you for hanging in there all these years on this task.
Been good.
How about the pharmacy act?
Yeah, good morning. So
Morning.
the pharmacy TAC did not meet at the last time, but our report for the October 2nd meeting, because both the chair of the pharmacy TAC and myself could not attend at the last meeting. I do not believe so. I was going to report on that if that's okay with you, Dr. Schuster.
Sure.
October 2nd.
Yeah.
Okay. There was, so the first thing that came up was a little bit of discussion about vaccine counseling. Because still, although that has been in place for a while, we still have a couple of MCOs that are not reimbursing on that, which was WellCare and Aetna, according to the report here. 4 of the other 6 were, of course, now Anthem is not in that group. So at any rate, so that was discussed. There was also some at the previous meeting, it seemed like there was some question as to if the report had been submitted and considered by DMS. So a review of the following motions I'm going to include just to make sure that those are addressed, because there was some question about that. The first one, and I think we did discuss this before, was there was a motion to, and it asked for the Department of Medicaid Services to pay pharmacists for the administration of long-acting antipsychotic medications. There was discussion around that this reduced the cost for an office visit and also allow the patient to have better access to that care, which can be provided in a pharmacy, and thus includes ease it and give better adherence. Okay. So, some of those medications are, as we all know, are Abilify, Zyprexa, Invega, Risperidol, and others. And of course, this is a very vulnerable group. When you have them there, important to give it. But pharmacists aren't being paid for the administration for this. And so I think that would really help if we could do that. Other maintenance medications as well, which could be administered at the pharmacy, and also decrease, burden on our patients and cost for additional visits and such as B12 vaccine, B12 injections, allergy shots, testosterone, those type of things. So that is with the 2, some ask there from the pharmacy TAC. Okay. So other things that were discussed, obviously, they were asking for Medicaid to, consider providing clinical or counseling on monitoring for community health workers. That has been, that could be done under doula services is in Senate Bill 74. And there was a little discussion on that. Additionally, they just wanted to bring this up that, Medicaid in other states are covering many things such as diabetes self-management, MTM, which is very critical, medication therapy management for these patients, including compliance, counseling, packaging, those type of things. Those include, really help with adherence. They help with patients who may have trouble managing their medications. They come in the form of packaging, but also digital compliance monitoring, where people can actually see, where your providers can see what's going on and monitor those patients, which in my experience, came from long-term care world and service a lot of patients out in the community. That is critical. They need to be able to take their medications and need to have people might be able to, help them better if we had some of these services for our patients. I think that's very important. The other thing that did come up too was TB skin testing, and that is something pharmacists can do within their scope of practice, and it's critical for public health as well. So just to support this, there's some discussion about, and we've brought this up in this meeting before, Senate Bill 48, which was passed in 2021, which did allow for pharmacists to be paid for services that are similar, that are provided by other practitioners at the same rate of a non-physician practitioner. And I'm summarizing this, obviously, within their scope of practice. And so there is precedent for that within our state that we've seen. But But at the end of the game, they also, I was asked to mention that they discussed that it appeared that many of their concerns are not being heard and addressed, and that they would like for the department, I've got a little note here, hold on, I apologize.
Excuse me.
Hold on just a second. They'd like to see the Department of Medicaid Services place patient care in front of all priorities, and that work be done within the department to understand what patient care and services that pharmacists currently provide to better care for our Medicaid beneficiaries. And that all centers around all of this of making access to these services and making them billable for pharmacists within their community so they can help take care of these patients that they know and that they care for at this time. Thank you.
All right, that is a long list, but I'm delighted, as you know, Kathy, to hear the long-acting injectables are on there, because you and I have had that discussion. It's so
We
critical.
have, yeah, and I think it's very critical because that's a very vulnerable population, as are all of our patients, but these in particular, and to just at this, the reimbursement for these medications, pharmacies are lucky if they paid the cost of the drug. And so, they really do need to be reimbursed for the administration as well. Because that is a clinical service and it needs, I really, really feel strongly is for some of these medications that we need to try to take a forward step in that direction if we can.
So just to be clear, are these in the form of recommendations that we need to vote on? And
These two recommendations were brought up at the past meeting. And there was
Okay.
some confusion as to if the report had been submitted. So there was also some confusion to see if these two recommendations had been addressed by DMS.
And Aaron, I think that I saw the DMS did respond to the pharmacy recommendations.
Yes,
just
ma'am.
yesterday. Is that right?
Okay.
Yes,
Okay.
ma'am. They went out
That's fine.
I was
and
gonna say, because we had some BH TAC recommendations, Kathy, and they came literally the morning that we were meeting that afternoon. So
And
they,
it is-
I appreciate that.
they were later getting out, I think, than usual. So they have been
So-
responded to.
So I say that we don't need to. So,
Okay.
okay, thank you.
All
Just
right.
more of
And
a
I-
clarification. Okay.
Yeah.
Kathy, just so you know, I
ma'am.
noted on the responses that they were brought to the MAC in, I believe, the September and November. Then November had a few extra medications, so we kind of combined that into one. So
Okay,
it's
so-
noted on the response.
Great, thank you. So Ron had submitted that report in November. Okay, thank
Yeah.
you. Appreciate that.
Yeah, I do think that, the discussion about putting patient care, at the top is what we all are about. But you've brought up some other food for thought, I think, Kathy, in terms of, people go to the pharmacy, particularly when they're located inside the grocery store or whatever, or they, or they're out and about. And so instead of just going with the sole purpose of picking up a bag of medicine or whatever, that there are lots of other things. I mean, certainly the COVID shots and the flu shots and so forth are really being touted by the pharmacies, at least here in the local that I'm familiar with. So important to bring that forward. Yes.
Yeah.
Eric?
Yes, I think it's very important because, making sure, all of this, reviewing their medications and all that is so critical for these patients. And so we would
Right.
like to see some form of way to be appropriately compensated for those services. So,
Yeah.
thank you.
Okay. Thank you. Did you want to say something, Eric? Right? No? Okay. Physician TAC, please.
This is Ashma Gupta representing the physician TAC. We have not met since the last meeting. Our next meeting is planned in May.
All right. Thank you, Ashima. Primary care.
Hey Sheila, this is Barry.
Mm-hmm.
The primary care tech met on October 24th, and we didn't have any recommendations, but we do have new members, and we do have a new chair, John Lilliebridge, and he apologizes for not being here, so that's why I'm giving the report.
Okay, thank you.
You're very
So
welcome.
new members are always good. New chair is good. Thank you, Barry. So
New blood.
when are you all meeting again?
March 27th.
Okay. So are you all only meeting every 6 months?
No, I think we just, no, we're back on, well, yeah, I guess we are. Our next meeting is March 27th, and then we have one in December scheduled. So should we meet quarterly?
I would assume that there would be more business that would necessitate at least a quarterly meeting. That seems,
March 27th is our next MAC. Give me just a second there.
Oh, I apologize. I'm sorry.
I think, the primary care attack.
It's on the 27th of February.
Okay, I'm sorry.
yeah.
It's okay.
Got too many text messages rolling in, trying to figure out which one's which.
Yeah,
So-
I guess I would be surprised, knowing how broad primary care is, that you don't
I
have
would
more
imagine we are
business to
meeting
talk
quarterly.
about.
Yeah, I believe the primary care TAC has moved to a quarterly meeting, and it is up to the TAC to make the decision on their meeting cadence.
I'll take that back, Sheila. I may have misspoke. Sorry.
Yeah, Veronica thinks that you all are meeting quarterly. I'm just,
You are
trying to get-
meeting quarterly, but excuse me, I got tongue tied. If the TAC decides they want to rearrange that schedule, that's something we could, discuss in the next meeting or, just in an email. So just let me know, Barry, but I do have you guys scheduled for February 27th.
That was John and I. We were texting back. Apparently the MAC is March 27th in December.
Right.
I apologize.
Yeah.
So,
all right. Thank you, Barry. And we'll look forward to meeting your new chair.
you're very welcome.
When we meet in March. And then last but certainly not least, the therapy TAC.
I do not see someone on, but they are scheduled to meet at the first week of February. Oh, no, my apologies. I'm sorry, my calendar just froze. If you'll give me just a moment, I'll let you know their next day of meeting.
Okay, thank you. So we have recommendations, a number of recommendations from the Consumer Rights and Client Needs TAC, and I would entertain a motion from a voting member to accept those recommendations and send them on to DMS.
I'll accept those and make a motion to accept and move on.
A second.
Kathy and Beth, great. Any discussion? All those in favor of moving along the consumer rights recommendations to DMS signify by saying aye.
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 All right, opposed, like sign. All right, wonderful. Thank you very much. And we appreciate the reports for those of you who were here. I do think that hearing what the issues are is helpful to the MAC members. So under new business, we have a couple of things that Dr. Eric Wright, who's a voting member of the MAC, brought forward. And let me see if I have this right, Eric. United Healthcare is covering now equine therapy. And you were wondering about if they had an update or could give us some more information about that. And then we wondered if any of the other MCOs are also covering that service. Is that right, Eric?
Yeah, that's correct. I received an email from a Kelly Dugan who works out of St. Louis that they are contracted with United Healthcare Kentucky, just putting together a provider network to offer therapeutic riding services or equine assisted therapy. Beyond PT, OT, and speech, but also mental health as requested by their members. The benefits covered, they said reimbursable, and they are piloting this, and it appeared to be Warren, Jefferson, and Fayette counties. The reimbursement rates are for therapy sessions for a PATH certified instructor, which is one of the requirements, is $75 per session for therapeutic writing for 45 minutes, and then 45 minutes therapy service by a registered or licensed psychologist, behavior therapist, mental health disorder specialist, social worker, physical speech and occupational therapist is $120 per session. And I just wanted to make sure that I'm understanding that correctly, if that is actually something that United Healthcare is offering here in Kentucky. You know, sometimes you get this information, you just are like, this is in fact true. And if it's true, kudos. But then the other question is, are other MCOs going to be offering these services? And so I was hoping somebody from United Healthcare could speak to this, and then maybe see if the other MCOs are going to be involved as well.
Dr. Wright, this is Greg. I'm our Chief Operations Officer at United Healthcare in Kentucky. So you are right. We have implemented a new program with equine therapy. We're also doing music therapy alongside of it.
She mentioned that as well. Yes.
Yeah, so we're excited about it. I will tell you that we are piloting it small. So the eligibility for members is not every member. So it's open to our members who have an autism diagnosis, members who are in an adoption assistance category, and former foster members between the ages of 18 and 26. So those would be the opt-outs from the SKY program. So we're testing this in a small group of folks and hoping that it can be a benefit to those families. I can confirm, I won't get into all the fee schedules and things like that. We are working with a vendor to manage this program. It's not localized right now, so we're open to all requests from our members who fit those categories. But you're right, we are excited about it because we think it can be a benefit to families. These services have made an impact on people that are close to us. I will tell you, Dr. Wright, as we think about this, we think about the things that impact even our families. My adopted son, he was adopted out of foster care. He has benefited greatly from equine therapy. Another of our team members, her child with autism, has benefited greatly from music therapy. And so the members that we interact with, we hear these needs. And I got to speak to some of them personally. Some of our members who are in an adoption assistance category, I got to speak to their families. And when I introduced this new benefit, they were very excited about it because some benefits that exist within a foster care program don't go with the child after foster care ends and once they're into an adoption assistance category. So we're really excited to extend that out to these families, and we're hopeful that it makes a difference for them.
Well, Greg, my background is I'm a licensed professional counselor and a former school counselor. I've adopted 2 children, one of which is from the Ukraine and one of which is domestically adopted here locally. And then we have a daughter with Angelman syndrome, and our family has been involved with equine assisted services, and we run a small nonprofit. That's how I was reached. And when I heard about it, first off, I want to just give your all's organization credit for being willing to step into this realm. A lot of this is in response to, I think, what is happening in Colorado with Temple Grandin and her research as well at Colorado State University. I'm extremely pleased to hear this. I'm curious if your infectious excitement will bleed over into some of the other MCOs, because I would surely love to hear from them. But regardless of such, I just want to give you guys credit for making such a move.
Thanks so much.
Thank you, Dr. Wright. This is Krista Hensel. I'm the CEO for the plan. And Greg, I just want to validate as well. We are introducing this program as a part of one of our value-added benefits and services. So where we take a look at things that aren't necessarily covered by core Medicaid, but we believe are worthwhile for the families and members that we serve, and worth, like you said, Greg, piloting and seeing what kind of impact we can make. And what a better thing than equine therapy in the Commonwealth of Kentucky, which is a heart of horse country.
That's
Greg,
right.
did I get that right? It's one of our value-added benefits, correct?
Exactly right.
Sort of
Yes.
through this standard.
Yeah.
Like,
All right. Well, that is very good news. I'm sure we have other MCOs in attendance here at the MAC. Are there any other MCOs that are offering this kind of coverage?
Good morning, Dr. Schuster and
Good morning, Stuart.
Dr. Wright and everyone. I was going to say, so this is Stuart Owen with WellCare. I would like to sign up for the equine therapy. And that was one of my questions. Is this a value-added benefit? And you're saying that it is?
It is. We added it as a value-added benefit this year.
Okay, that was yeah. We're not doing this, but this is fascinating. We absolutely will explore it. This is really cool.
No better place for equine therapy than Kentucky,
Yes.
right?
And right here in Kentucky.
No shortage of horses.
That's right.
So, Greg, is it restricted to those counties that Eric Wright mentioned, or is it statewide?
It's statewide. Of
Okay.
course, that depends on adequacy, as every service will. But we're going to make an attempt to get every person who requests, who meets those criteria that we talked about, we're going to make an attempt to get them scheduled with an equine therapist or music therapist, if that's what they're interested in.
Okay, great. So it's not restricted to those populated counties necessarily. All right, wonderful.
Can I
Any
ask,
other-
can I ask another question of Greg?
Sure.
Obviously, I'm passionate in this realm, therefore, that's the reason we run Cope Soap Equine Assisted Services in Jefferson County. My family does as part of my private practice. My question is Greg, do you have the language that you could share related to who and is it benefiting from this, a value-added benefit? Because I would love to get a copy of that, and I'd be glad to send you a private chat, I guess, if I can, to send you my email, or you can just
Yes.
search my website. I appreciate that. And the music therapy is something that here at the University of Louisville, where I work full-time, I've worked with that department to see that benefit be realized as well. So I'm really excited about that. I actually went up and spoke to Morgan McGarvey, his team, a few years ago, just to start that process. And I think that we're moving in that direction as well. So I'm extremely proud of United Healthcare for moving into this area, and I'm hoping other MCLs will follow suit too.
I really appreciate that. I'm going to put my email in the chat. And so if you've got questions about it, feel free to reach out to me. Something, obviously, Dr. Wright, you and I are very excited about. If others have questions about it, I'm always happy to talk about it.
Okay, that's a great way to do it. Thank you. And thanks very much for being on.
Thank you. Yes.
As a clinician who worked with kids on the spectrum for years and years and years, I think this is very exciting. Eric, you also had a concern that you were hearing from people about the respite rate changes, and you're hearing from participant representatives of waiver recipients. You want to talk about that?
Yes, I'm engaged with a number of social media channels related to the Michelle P. waiver in particular, related to respite. And I guess the news came out that there was going to be some changes in billable rates related to that. I think the concerns that I just want to bring forward and to see if I'm understanding this correctly, the biggest concern is that a lot of these individuals are using participant directed services. They've been hiring for respite for many years. Most of those are contracted typically when they renew for that benefit. And when those contracts tend to use rates that have been, approved by Medicaid and their case managers through their fiduciary agencies for years, what we are hearing is that the rate is reduced now, which I guess there's two rates. There's rates for individuals within the individual's families, specific to siblings and parents, but there's a rate that's outside of that with potential PDS workers of $21.63, I think, for an hour, if I'm not mistaken. And if I am, somebody can help clarify. But a lot of these individuals have already signed contracts with their case managers and fiduciary agents for rates that are higher than that based upon precedents that have been set from years previous. Additionally, I have some questions. So one of my questions is, how does that work? Does it work that is it billable hours while in the care of the respite provider, or is it just certain hours like non-sleeping hours? I'd wanted to get some clarity to that. And then the other thing is some agencies, nonprofits, even like, for example, Easter Seals used to provide a service for respite, but it was for a camp that was over a week period of time. Just a lot of questions that I think are coming up with the change in respite billable rates. And so I'm bringing this to the table to get some clarity to this and hopefully get some answers.
Is there anybody on from DMS that can respond to Eric's questions?
There's a lot of requests within what you've asked for, Dr. Wright. So we did, and I think we did our best to communicate the proposed rate changes last year. We posted the waivers with the rates in them. Those are tied to the budget, the budget that we received to cover an increase for pretty much most of the services related to the rate study that was performed. I don't know, Alicia, if you can speak to that a little more.
Yeah, I can give you a little bit about the rate changes. Previously, you are correct that it was based on just a dollar amount per year. And that is not the way that usually services are set up. So within the rate study, and all this was out for public comment, all of that. But the new rate for respite is $5.92 per 15 minutes. We looked at, and with a limit of 1,312 units per plan of care year, that actually is up to, instead of the $4,840 that they had the option of using prior years, they actually have $7,767 now and 4 cents to use. So while it may be, a reduction based on how somebody may have historically paid over the $23.68 per hour, participants really have an access to an increased number of units at a rate that meets those CMS requirements of the efficiency, economy, and the quality of care. So, and again, participants should always utilize the service, this method, consistent with their level of need, documented in the assessment. Of course, it's person-centered.
Can I ask a couple follow-up questions?
Yes, sir.
The 2368, I'm hearing differing things across there. Is that just for a specific population, or is that across the board rate?
That's across the board, but now I do not, we don't get into determining taxes and all of that with the participant directed population. So sometimes there are, I would say, an amount that's withheld maybe from, a paycheck, kind of like our with taxes and stuff like that. Definitely, I do not get into the whole participant directed and those requirements, but that may be what they're referring to. And it all kind of depends. Do you live with the participant? Do you not? There's some different, I guess, qualifications maybe on those.
Okay. Another follow-up question. Waking hours or sleep included in that, in a unit?
So I want to go back. I don't have the waiver application or everything pulled up in front of me. So I would like to go back and just take a look at that. I know you had said waking hours I wrote down, and also weeks at camps.
Yeah, like there's been some possibility, because what the flexibility of that rate was allowed a lot of individuals to have flexibility with the provider of that service, whether it was traditional or even a non-traditional provider, like our traditional or PDS provider. And so, I mean, obviously I'm not trying to dig too deep into the weeds here, but there are some things that with the constraint on units, the way what's doing, I mean, first off, thank you for the increase in the amount. If you use the units the way they are, the concern I think seems to be like, what if these individuals had signed some contracts with these individuals at a rate? What is the, like, so that was a concern that came up. Are those individuals that, our contracts considered be legally bindings with these AAA agencies like KIPTA? And then all of a sudden you're changing a rate change with an employee. That was a big topic of discussion that I think still needs to be addressed, because I don't think your case managers were aware
We're
of
sorry. Your conference is ending now. Please hang up.
Sorry, what happened there? Okay.
I'm sure.
Yeah, so I think the biggest thing is because I don't think, while there might have been discussion about rate changes and the waiver rewrites, I don't think the case managers were informing, or there was they weren't informing them when they were doing renewals and contracts were signed at a higher rate. That's a big concern. And so, and then the next is truly about the flexibility of the waiver. So I appreciate if we could get any other clarity to that. I think it's going to be important.
Yeah, I mean, with CMS has approved for us to pay, up to the $5.92 a unit. Obviously, somebody might get paid $4 a unit. Not everybody's going to get just paid maxed rate. But with CMS, that's what they have approved. If there are contracts that are higher than that 2368, those will need to be redone. But again, the participant, I'll go back to saying this, the participant can now, instead of $4,840, they can now receive up to $7,767 if needed, based on their person-centered plans. So this is really a great thing for our participants and allowing them to be able to use respite.
Dr. Wright, it might, since this is a new business item, it might be helpful to us if you could send us your questions in writing, and so we can make sure that we're addressing exactly what your questions are.
Yeah, we brought this up pretty last minute when Eric put these items on, and why don't we carry this item forward, Eric, to the next meeting?
Thank you.
And in the meantime, why don't you and others who might have questions, the folks over at the IDD TAC may also be interested in following up, or some of the folks that are in the audience today may be interested with questions that they have. So let's get those together. And Veronica, who should we send those to?
You could send them to Kelly. That'd be great.
To
Aaron and Kelly, or Aaron.
Yeah. Okay. Yeah, send them to Aaron, Eric.
Thank you.
And Kelly, and then we could gather those and put them on the agenda. I'll make a note here to put this on the agenda for the March meeting. Thank you. And thank you, Alicia and Veronica, for responding. I think you've gotten some information, Eric, and then we could follow up to get the rest of it. Okay.
Yeah, thank you, Dr. Schuster, for allowing us to have that conversation, and we'll get a few questions out that I'm receiving, and I'll get them over to their team.
Yeah, great. Thank you. And then this other is something that we touched on very briefly at the last meeting, and it has to do with, I think, what's called closing the care gaps. And I think that what I was hearing from some providers was that they were hearing from their patients that the MCO had been to visit them and provided some services, but nobody seemed to know except the patient that those services had been provided, and they were screenings and maybe even some direct care things. So I'm trying to get a handle on what closing the care gaps activities are. Is that what we decided to do, Aaron, to kind of put it out there so the MCOs would have a chance to respond?
Yes, ma'am.
Okay.
And then if we need to request it in writing, a review for the MAC, we can request that since it's under new business.
Yeah. Okay.
I can address from Dr. Schuster from a United Healthcare perspective. If it's closing care gaps, we have provider quality consultants that go out and meet with especially large primary care practices where we have a lot of members, and review what we call our PCOR, or our patient conditions and outcomes reports that are produced on a monthly basis that display care gaps. We have a variety of different programs, value-based programs with providers to close some of those quality gaps, oftentimes associated with one or more HEDIS measures from NCQA. So that's the backbone of what our program is actually centered around PCPs, ensuring that all of the claims data that we have, we're able to kind of share back. So if somebody got a vaccine at a pharmacy, that the primary care physician sees that that gap was closed, and they're not trying to chase down that particular patient for that particular item. So that's one of the mechanisms that we try to keep the primary care office as the quarterback in the system.
So it sounds like you're gathering, or if you're aware of information because of the claims, you're doing that feedback loop back to the
Correct.
primary care provider.
Yep, through a monthly report.
Okay. Are you all interacting directly with patients at any time? Making home visits or that kind of thing? That's what I was
Our community health workers will sometimes go out as a part of if somebody is enrolled in a case management program, but that is typically not providing a medical service. It's more at helping the patient advocate, helping them get scheduled, helping reduce any transportation barriers, that kind of thing.
Okay.
Sheila?
Like, we do have clinical teams that engage with members.
Yeah, Beth?
It seems like we're talking about two different things, because there's one thing that we get letters from the MCOs about items where the patient hasn't had certain tests done or basically routine screenings and things like that, like mammograms, hemoglobin A1C for diabetics, screening for colon cancer, that kind of thing. We get notices, and I can't tell you specifically which MCOs send out those notices. I haven't paid that much attention to it. But it's just a notice saying, that they need these things, or the last time that they had it. And sometimes they've had it and the insurer doesn't know that they've had it. I don't know why they don't know, but then we just respond that they did get that testing done and when they got it. But then there's another thing. There's another thing though that actually has either a physician or nurse practitioner or PA, mostly it's nurse practitioners, I think, go out to the patient's homes and actually examine the patients and talk to them about their needs and their health and what the patient thinks that their needs are. And we get reports on that as well. And I can't, again, tell you which MCOs are doing that, but we get those reports as well. So it may be two different things that we're talking about.
Yeah, that latter is what was described to me, was that there was some provider type who was going into a patient's home and doing some exams, or maybe even doing some screenings.
Sometimes, yeah, sometimes some screening, but mostly exams and questions to the patient about what their needs are and what they think that they could benefit further from, that kind of thing.
I want to make sure to, if you guys provide any examples, we can help understand. There are programs in other lines of business for United Healthcare, as an example, like Medicare Advantage, where what you're talking about is more of this house call. In those house calls, a report is also generated when that house call occurs and is sent back to the primary care physician, so they understand the nature of that appointment, what activities occurred, next steps, etc.
Yeah, and this is Michelle Weichel from Passport by Molina. We have a similar process to that. It is primarily nurse practitioners, but they do go out and meet with targeted members in their homes. They can do in-home assessments, trying to get an idea of what chronic conditions are happening for that member, help coordinate their care with their primary care physician. They can do some in-home diagnostics. So they can do like an A1C, they can do a urine, they can leave the patient a Cologuard, those kind of actual care gap closures when it comes to HEDIS can happen in those visits. And then we will, there is a notice or a summary of that visit that goes out to the primary care physician that the member identifies during that visit, right? So if the member says, I don't have a primary care physician, then there's nobody to send that document to. But those, the intent of those in-home visits is to reach members who are not seeing their doctors on a regular basis or who appear to have chronic conditions that aren't being appropriately managed. And that's how we target who we go outreach. I'm not sure who was speaking for United. That certainly does happen, I think more prominently in the Medicare space than it does in the commercial or Medicaid space. But that does occur, at least for Passport by Molina, that does happen across all lines of business. And somebody had said something about sometimes the MCOs don't know when a care gap has been closed. A lot of that, there is definitely an issue between a true gap in care where the service needs to be rendered versus a gap in data. And that's because the member might have had something done with their prior MCO. Colonoscopies are great examples because they last for 10 years and we may not have record of it, even though the member had that particular diagnostic test a prior year, or we don't get actual lab values. So the member might have had an A1C completed, but we don't know that the member's result was 7.5. So there is definitely a strategy that at least at Passport, we try to address both of those lanes of, is it a gap in care or is it a gap in data? Because the call to action for each of those is different.
So you're doing that with Medicaid clients, is that right? Passport is doing that with
Yes.
Medicaid clients?
Yes, we absolutely do that. And all of our providers who are in value-based contracts get monthly reports from us that tell them who their members are that are assigned to them, when the last time they were seen in their office, when the last time they were seen for a well visit, as well as any open care gaps, right? And that's defined by NCQA HEDIS. But you know, this is a member that we don't think's had their mammogram or we don't believe's had the appropriate immunization that's recommended for their age, that kind of thing. And then we work through if there are any data issues. We certainly, and I think all the payers like to the degree that we can get automated data sharing to get feeds out of people's EHRs that will help reduce the times that we go out and ask a provider for a record because we don't have documentation that the care gap was closed. That automated data sharing, data connectivity is huge for reducing the abrasion in the provider office, and then also accurately reflecting what are truly care gaps.
I'm curious about how you notify the person that you're making a home visit and how clear they are about who you are.
Yeah, so at least
I
for
think-
Passport.
Yeah.
Sorry.
Go ahead.
Now, at least for Passport, we are very clear in communicating. Our team is called Care Connections. Those nurse practitioners are very clear in communicating that that they are not their PCP and they are not replacing PCP visits. That what the intent of that practice is, and then they'll actually, while they're there, help schedule a visit with the member's primary care physician if they're willing to do that. So I think we do a really nice job of communicating what the intent is of that visit, and that in no way it is a replacement of the need for that member to engage with their primary care physician.
Do you have interpreters?
We do have interpreters.
So you take an interpreter with you if you are aware that English is not the primary language?
No, those are going to be telephonic interpreters, with the exception of Spanish. We do have some Spanish speaking care connection nurse practitioners. But otherwise, the number of languages that are spoken is too diverse for us to be able to bring an in-person translator to those kind of visits.
But you use the telephonic while you're making the visit.
Correct. The same as I think a lot of the providers would do in their own offices. There is you dial in and get the interpreter for the appropriate language to adjust those members' needs.
Okay. All right. Well, that may be what I've been hearing about. That sounds like the concern or the question, I guess, from I was hearing from PCPs. Thank you. Stuart, do you have something from WellCare?
Well, yeah, I was going to say extremely well described by both Michelle and Krista. The bottom line is there is member contact and provider contact. It's both that's involved. And then also, even the claims lag can be a lack of data insight as well. Just we don't know till we get the claim. So, but it's a combination of both member and provider contact with different teams, quality team, care management team, provider relations even as well.
Do you make home visits as Passport was describing?
I believe we do, but I don't know. I don't know for certain, and I don't have anybody on that could verify that. I can check, but I believe we do.
Okay. All right. Well, that's very helpful. Anybody else? Thank you, Michelle, for that as well. Anybody else have anything they want to share?
This is Megan Johnson, Health Services Officer for Aetna. We provide, very similar to what Michelle described, we have quality practice liaisons that meet with our providers that are in VBS arrangements and notify them of open care gaps, as you mentioned, and then any care gaps that have been closed elsewhere where they're not at that PCP. Our care management team does not provide direct patient care. We use a vendor solution to do those visits, as Michelle mentioned, that Molina does as well, and then that information is communicated with us. But yes, that is not intended to replace the PCP. It's used as an adjunct for those members who may not be able to visit their PCP or have some barrier and need an in-home visit. So,
and what's the name of the vendor, Megan?
We have Signify.
Okay. So I don't want to misconstrue this. I don't think that the PCPs were feeling like
they were communicated.
The MCOs were stealing their patients. I think it was the confusion that they were hearing from the patient as the patient was trying to tell the PCP, they had their blood drawn, or somebody came and listened to their heart or talked to them, and the PCP's like, well, you're not getting home health. I mean, there was just this disconnect.
Right. Yeah, and I think we could probably all do a better job of communicating that with the member.
I would suggest that strongly. I'm so glad that you recommended that, Megan.
Yeah, I appreciate that feedback.
Yeah, I mean, I think, and particularly, Michelle, it sounds like with Passport by Molina, because you all are doing a lot of that. And, I love nurse practitioners, and I'm glad that they're out there doing this work, but a little more communication with your provider community, just reminding them that you provide that service and how you choose people and, the feedback that they should be getting. Because I think the concern was coming from the providers, because the patients were like, I don't know who these people were, or I was confused, or was that okay? Or, that kind of thing. And then the providers tried to figure out who the heck was going into the home and doing whatever they were doing. So a little more communication, I think, would close that gap. Okay. Thank you all very much. This has been very helpful, and I will relay this back to people that I was hearing from. But very helpful. I appreciate it. I don't want to shut anybody out. Was there anybody else? Okay. I think we're at the end of our business. I'm going to give you back 10 minutes of your day, which is a good thing. So we're going to meet again on Thursday, March 27th, same time, same station. And I thank you all for your participation and input. And Aaron will help, and Kelly will help us get the PowerPoints out that were shared with us and so forth. And if you have some other questions about the change in respite rates and so forth, get those to Aaron so that we can get those answered at the next meeting. So have a good day, and we'll see you in 2 months.
Thank you too, Dr. Schuster.
All right. Thank you.
Stay
Take care.
warm out there.
That's right. Thanks.
Thank you all. Everybody
Good luck,
stay
y'all.
safe.
Bye now.
Bye.